All right, thank you guys for coming. I appreciate it. My name is Adam. As many of you know, my daughter Mackenzie is a WSS warrior. She's 7. It's really cool for me to be up here and share some of my experience in my career with you guys when it comes to musculoskeletal conditions in our kiddos. A little bit about myself. I'm a chiropractor. I've been doing that for 14 years now. I teach in higher education as well. So been doing that for 13 years. Anatomy, physiology, healthcare advocacy, all different sorts of classes. And so I'm really excited today to present. This is my first time presenting at a conference. It's my third one that I've attended. And so let's have some fun here. So there's Mackenzie. So I get a lot of questions. I'll see them come through in the Facebook. I know we're all active in there, and the different conditions that are associated with Wiedemann-Steiner syndrome when it comes to their growth, their musculoskeletal system. And so it's important to remember that all of these conditions that we see, it's not just WSS kids. There are all different types of syndromes, genetic components, where we see a lot of similarities with WSS kids and those with other syndromes. So like this is the biggest one, I think, when it comes to what we see most common with kids, and it's hypotonia. I'm sure we all can look back to when our children were born, when they were babies, and those milestones that were not being met, whether it was sitting upright or crawling or walking. And a lot of that is due to decreased muscle tone. Now, that's not necessarily weakness. And so I think there's a misconception of hypotonia is weakness, and there's a definite correlation with that. But think about if you were to hold a baby, right? And I think it's on the next slide, but if the baby's not able to sit upright or they're kind of falling over your hand, low muscle tone is present. And so we see that with a lot of Wiedemann-Steiner kids. One of the most common reasons why we do see hypotonia is a genetic component. And you're all aware that there's a big genetic component with Wiedemann-Steiner syndrome. So when it comes to hypotonia, it's not necessarily a muscle condition, it's more a neurological condition as well. So there's a system, a pathway, our brain, our spinal cord, those nerves that branch off of our spinal cord, for example. If that pathway is interrupted in any sense, we can see muscle hypotonia and muscle weakness. So it's not a disease. So when we are diagnosed, when our kids are diagnosed with hypotonia, that's not necessarily a disease, but it's secondary to something else. So there's a picture I was discussing. Decreased muscle tone, once again, baby's not able to hold themselves up. And then we see this continually as the child gets older. Once again, they're not walking at the age they need to be. So we see floppiness, which is decreased resistance with passive movement. So if we were to move like a baby's arm or leg, it's very easy to do. There's no resistance to it. We see mobility deficiencies. So sitting upright, crawling, walking is very difficult. Breathing and speech difficulties are also very common. I know with Mackenzie, feeding was a big issue with us when she was born. A lot of vomiting. And one of the reasons why we saw that was due to low muscle tone in her swallowing. So we went through, met with different doctors, different speech therapists, and we figured out we have to improve her muscle tone. We did thickening of liquids, and we saw an improvement with that. And then it was just continued therapy. And then a lot of these conditions I've talked about today, they do improve with age. Okay, so as the child is getting older, they're more active, they're increasing their neurological system. So that pathway from their brain down to their muscle tissue is continually progressing. So hypotonia, as I said before, does not mean weakness, but they can occur together. So if someone with hypotonia contracts that muscle, they can have strength, but once again, at rest, that's when we see the decreased resistance. Okay. Once again, very common with the WSS kiddos. So how do we treat hypotonia? Therapy, occupational therapy, physical therapy, speech therapy, working on balance and coordination, especially during these developmental years, right? Trying to fire that nervous system, improving their motor and sensory skills. Once again, this is what these therapies are really important. With Mackenzie, outside therapy, school therapies, really just pushing it as much as we can. And ultimately, the goal is to improve that neuromuscular connection. Okay. We can also supplement neurologic systems, B vitamins, things of that nature, just to once again put our kids in the best position possible when it comes to their growth. Congenital block vertebrae. This is very common with Wiedemann-Steiner syndrome patients. Most commonly, it's at the C2, C3 junction. Now, in our neck, we have 7 cervical vertebrae. So the second and third are where we commonly see the fusion, although it can occur anywhere in the cervical spine. There is definitely a genetic component to this as well. Now, those with WSS, we tend to see that C2, C3 fusion, but there are other conditions where block vertebrae are also present as well, not just Wiedemann-Steiner. A lot of times, it's incidental finding. You have x-rays, you have imaging, and then that's where we see that it is noted. Most times, especially in younger kids, they don't experience too much pain, discomfort, where they can't communicate to us that they're experiencing any kind of issues. So it's something that we kind of just tend to find on accident. If there are multiple levels of fusions, that's another syndrome, okay, Klippel-Feil syndrome. So this is where we see 3 or 4 levels of fusions together. Okay, now the spine works in really neat ways, and it has movement patterns. And if we have these fusions, our movement patterns now become limited. So that's where we start to see lack of range of motion. We see muscle tightness, joint compression, and those are things that later in life may affect us. So as I said, usually no symptoms are noted. We don't, like I said, experience pain with children for the most part. Limited motion, possible joint pain if there is nerve compression. So in between the levels of the vertebrae, we have nerves that exit at each of these levels. If we have that fusion, there's still an opening for that nerve at that level to come out, but sometimes it's smaller. So we may experience radiating pain or localized pain in the shoulder or arm. Possibility of cartilage disc breakdown at levels above and below. So biomechanically, like I said, our bodies are made to work a specific way. And when we have a fusion, the levels above and below now take on extra load and they have to work differently. So that's where we see in our later years, maybe we have arthritic change at these levels, disc degeneration, because your body's having to work a little bit differently than it normally would. When you have a fusion, you don't have to worry about surgery or doing anything different. It's just kind of, once again, maintaining range of motion, muscle flexibility, strength, just allowing the biomechanics to work the best that it can. Scoliosis is a very common condition that we see in the spine. Scoliosis is a lateral or sideways curvature and also has rotation of the vertebrae too. So if you guys maybe have had x-rays done on your children and you see there's maybe curvature that is present, it's not necessarily scoliosis. We can have like a lateral curvature, just an abnormality of the spine. Scoliosis usually has a degree that it has to be met with that rotation of the vertebrae to be a diagnosis. Most cases are idiopathic, meaning we don't know why, but ultimately it goes back to that genetic component, right? So all of these things that we see, genetics control our entire body, and so scoliosis is one of those as well. Okay. Hypotonia can have an effect when it comes to scoliosis. So our body, when we have the curvature in our spine, is having to work against that. Muscles are overworked. If we have hypotonia and we have that, not necessarily weakness, but we don't have stability, that can lead to, once again, further problems down the road. So as I mentioned, no direct correlation with Wiedemann-Steiner syndrome, but once again, genetic components are always a factor here. So as I said, it kind of depends on the degree. Some scoliosis cases are 10 degrees of curvature in the spine. Others can be 45. In my 14 years of practice, I've seen some really bad cases. It almost looks like an S curve in the spine. This can occur in the neck, the mid-back, or the lower back. Early diagnosis is important, okay? So when I was in elementary school, I remember we would go to the nurse and they would have us bend over and they would kind of look at our shoulders. That's an easy way to tell, just to see maybe if there are abnormalities with the spine. So if we do see, for example, shoulders are uneven or the hips are uneven, or even standing, they may be positioning themselves in a specific way, could be an indication that we have curvature of the spine. Most cases with scoliosis are non-surgical. There's a lot of risks as well when it comes to surgery. For example, if we're inserting rods and as the child grows, now we have to lengthen those rods to help maintain the proper alignment. So there can be a lot of complications with that as well. So when we have scoliosis or curvature in the spine, we can see other systems affected. So our lungs, right, in our thoracic cavity, if there's curvature in the mid-back, the lungs may be compressed, so it can be more difficult to breathe. If it's severe, it sometimes can put more stress on the heart as well, too. So breathing can be affected. Conservative treatments are always the place to start. Me being a chiropractor, that's kind of where I always look to. What can we do to avoid surgery? What can we do to avoid, medications if possible? And so physical therapy is a great way when someone with scoliosis to see improvements, working on mobility and core strength. There are specific programs that are out there that are focused specifically on scoliosis, and depending on the curvature, different kind of methods of exercises can be performed. Once again, the earlier we can detect these, and as that child grows, the better prognosis we will have. Once we become skeletally mature, 20, 21, 22, we're kind of more in a locked-in place. But if we catch these things at a young age, as the body grows, if we're putting the spine in a better position, we can see better results down the road. Adjustments can definitely be helpful for scoliosis. Movement, okay, that's the whole goal of the adjustment, is get motion in the spine. And so allowing the biomechanics of those vertebrae to work properly. Diet, exercise. If we're overweight and we have scoliosis, it stresses the spine even more. So we want to try to avoid that. Bracing at a young age is also very common. So depending on the severity, I know there's cases where children have to wear braces for like 15 hours a day. And so as they're growing, trying to allow that spine to grow in the best position it possibly can. And then monitoring is important as well. So x-rays can be done, yearly to kind of look at the curvature, assess how treatment is going. I did put in here, there have been studies. I know a lot of WSS kiddos are on growth hormone. And so there is no direct correlation with like scoliosis and growth hormone. But once again, if we are taking growth hormone, that affects our spine. And so there can be changes that we see, but once again, nothing of a direct correlation. Posture, not just for WSS kids, everybody in here, right? I'm guilty of it myself. So WSS kiddos, hypotonia, right? These are things that are going to affect our posture. The blocked vertebrae as well, as we mentioned before, it alters the biomechanics. Altered gait pattern, flat feet, okay? Hypotonia, once again, we look at not having the stability in our joints. And if our joints are not stable, we see lots of issues that can arise from that. Tablets, video games, writing, sleep positions. I know there's some kids down there on tablets and their heads are down right now. Trying to put our children in the best position, right? So over time, if we're in improper posture positions, it's going to lead to more stress on these joints, on the muscle tissue, and that's where down the road we can start to see more neck pain, more lower back pain, and then even later in life, degenerative changes. So on the left, that's Mackenzie's neck. She, for whatever reason, will FaceTime me every day at work and want to see the x-ray machine. So I did do an image of her. And we can see with her on the left, it's very straight. Okay. I know it's tough to tell, but there is no C2, C3 fusion here. On the right, okay, we have a curve in our neck. Now, our neck has a natural curve when we look at it from the side. This is called a lordosis curve. And so naturally, it should go kind of toward the front of your head and then back up toward the base of your skull. When we have bad posture, we have forward head tilt, we're looking down, our shoulders are rounded, that natural curve tends to flatten, like we see with Mackenzie, and that puts more stress on these joints, puts more stress on the muscle tissue, on those cartilage discs that sit in between those vertebrae. So treatments, once again, physical therapy, chiropractic, all these conditions, when we look at the musculoskeletal system, really come down to two things. It's mobility and its strength, keeping things moving, keeping things strong. Adjustments can be helpful as well, just to once again try to restore natural, proper movement in the spine. Improving biomechanics of the body. Like I said, that's where physical therapy too can be a great resource. Making sure that we're properly walking, we're properly standing, for example, and not stressing different parts of the body. And then AFOs, I know some of the kiddos, are wearing them today, to provide stability for the ankles and for the feet as they're learning to walk. That was a big thing for us when Mackenzie wasn't walking. We got AFOs, gave her some stability in her ankles, allowed the muscles to work better, and she began to walk. And so that was a great thing that we saw. Improving our posture daily, like I said, that's just something that working with our kids, whether they are WSS kids or not, is very important. And so just making sure that we're always keeping everything at an eye level. Okay, so if they're on a tablet or they're on their computer or playing video games, eye level is going to be important because it's going to force their shoulders up and their neck in a proper position. If we see kids looking down, hunched over, long term, that's where we're going to see these effects. A lot of these WSS kids with hypotonia and have muscle weakness as well, lack core stability. And so core stability is so important just for the body in general. When we think about our core, I know a lot of us think our abdominals, right? Having a six-pack. I did about 4 or 5 years ago, not anymore. Our glutes are our main stabilizers of our core. Okay. And so when we think core, you want to think your glutes, your hips. If that is strong, that's going to provide stability for everything above. And then avoiding that forward head tilt. Chiari malformation, you may hear it also as Arnold-Chiari malformation. So this is a more serious condition, and there is some correlation with this as well with WSS kiddos. And so it's a condition where in our skull, our brain stem are essentially pushed downward toward the opening at the base of the skull, which is called the foramen magnum. A lot of times, the reason why we see this is due to a decrease in size of the skull in WSS patients. I know Mackenzie had an MRI when she was young, I think 1 or 2. It did show that her skull and her brain were smaller than normal. She did not have Chiari malformation, but once again, that's just a way that we can be more likely to have this. There are different types, and I'll talk about that here in a minute. So what happens in this, as you guys can see in that picture, our brain sits in the skull. At the base of the brain, kind of in the back, we have the cerebellum, which is really important for motor control, balance. And then our brain stem is the connection between our brain and our spinal cord. So that foramen magnum, that opening at the base, as we can see, contents are pushed downward through that. Okay. Studies have shown that the WSS patients tend to have smaller foramen magnums, which can once again lead to an increased risk for Chiari malformation. A lot of times with type 1 especially, asymptomatic, they're incidental findings through MRI. So here are the multiple forms of Chiari malformation. Type 1 is the most common. Okay? Parts of the cerebellum, so that small portion in the bottom back of your brain, are pushed downward. Asymptomatic, okay? And once again, incidental findings on MRI. This is more the pediatric side of things. So we can see as we get older, in our younger years, type 1 can still develop. More severe types, type 2, type 3, are usually during fetal development. So that neural system, the opening of the skull is not fully developed. And that's, once again, a genetic component to that. And that can lead to, like I said, more severe cases. So type 2 is the cerebellum and the brainstem are now pushing down through that opening. Type 3, there sometimes is an abnormal opening in the skull, and we have contents moving down from there. We can see a lot of symptoms with this. For example, there may be difficulty breathing. There could be eye twitching, central nervous system defects that we see with the more severe types. And then in type 4, the cerebellum is underdeveloped. So once again, that's really important for motor control and our balance and our coordination. Very rare though. So type 1 is the most common that we see. Like I said, out of the 4, it's the least severe, but it's something that you want to monitor to make sure we're not having issues with it as we get older and progress. There's a link on here. It basically talks about that cranial vertebral junction anomalies with Wiedemann-Steiner patients. So it's pretty long, so I'm not going to open it up here. Yeah, we'll have access to it through the recording. So if you guys want to click on that and take a look at it, It just basically has samples, a study that was done looking at the craniovertebral, which is the skull, and those first vertebrae, that junction in Wiedemann-Steiner syndrome patients. And then sacral dimple, maybe a lot of us have one of these in our WSS kids. I know Mackenzie does. It's congenital. It's an indentation just below the lower back, kind of right above the butt. It's mostly harmless. It's just a finding that we see. No treatments necessary for this. In some cases, we may have a condition called spina bifida, and that can be, that sacral dimple can be an indication that spina bifida has occurred. There are different types, just like with Chiari malformation of spina bifida. Most of them, same thing, asymptomatic, incidental finding on an X-ray. But with the sacral dimple, once again, it's just something that is there. There can be possible indications of a tethered cord. So that's where like the spinal cord is not moving freely in the canal, and it can actually attach to the tissue. And that can be more severe and cause further central nervous system deficits. If you guys would ever notice a lump of hair kind of over that sacral dimple, that once again, it may require further evaluation when it comes to spina bifida. Essentially what happens is during neurodevelopment, the spinal cord and the vertebrae don't fuse together properly. And so there could be part of the central nervous system that's not sitting in a good position. So that's something, if you do see hair there, to have it further evaluated. All right. So once again, just kind of wanted to go over some of the common conditions that we see with our WSS kiddos. I know we're going to stop the live stream here in a minute, and then I'm open to questions.